Thank you very much, and it's an honor to be asked to speak at this prestigious meeting once again. These are my disclosures. So, survival after AAA repair is less than survival in patients who do not have aortic aneurysms, and they also have a worse freedom from cardiovascular events. Aside from the typical age and comorbid conditions that impact late survival, also aneurysm size impacts late survival, as does whether or not you're taking an aspirin or a statin. And we know there was an early survival advantage with EVAR compared to open repair, but this is gone by 3 years. And then in late follow-up, we see that about 50% of patients after EVAR are still alive after 7 or 8 years. So we need a long-term, durable solution for aortic aneurysms. Other factors that impact survival include the behavior of the sac. We've shown that sac expansion is associated with a lower survival compared to sacs that don't expand. And more so than that, in a larger analysis, we showed that actually sacs that regress in the yellow line have the best late survival, with stable sacs being intermediate. And this was independent of whether there was an endoleak present or a reintervention. So we wondered how EVAS would compare to EVAR, and I think everyone knows the way EVAS works, with obliteration of the sac rather than allowing thrombosis to occur. So with EVAS, there was a steep initial learning curve, which then led to good early clinical results with a very low rate of type 2 endoleak, but at about 2 years, we started seeing failure modes with migration and sac expansion, which led to a root cause analysis and a refinement of the IFU. This leads to excellent clinical outcomes, but in a substantially reduced cohort of patients for whom the IFU can be met. And a confirmatory IDE study is currently underway. But one thing that struck us when looking at the all-cause mortality in the US IDE and the global registry, and it seemed to be better than what was seen in prior studies. And then as a comparison, we just compared the EVAS patients to the EVAR patients from a report from the Mayo Clinic, and at any given diameter, the 3-year survival seemed to be better in these patients, so it made us wonder even more. Now, why might that be? We know that there is frequently an inflammatory response after placing an EVAR. The post-implant syndrome is much more common after EVAR than EVAS, where it seems to be blunted with lower levels of CRP, white blood cell counts, MAE rates, cardiac MAE, and obviously endoleak. And that CRP rate stays elevated for at least a week after EVAR, but we don't see the same effect with EVAS. So we wanted to test the survival of these EVAS patients using the US IDE cohort. And we compared them to patients from the US VQI from the same time period and applied the same exclusion criteria. And then we calculated propensity scores and applied inverse probability weighting to compare risk-adjusted long-term or intermediate-term survival with Kaplan-Meier and Cox regression. Our primary outcome was overall survival, and a secondary analysis, we looked at survival stratified by aneurysm diameter. And this is the primary outcome. We see improved survival in the EVAS group compared to EVAR. It is statistically significant. When we looked at the smaller aneurysms, less than 5.5 centimeters, there was no difference in survival out to 3 years. You can see there's pretty small numbers here in the EVAS cohort, but these curves are completely overlapping to the time point where we've got good follow-up. However, in the larger aneurysms, we have a definite difference in survival with a hazard ratio of 2, with twice the mortality in the EVAR patients compared to EVAS. So we determined that EVAS had higher survival compared to traditional EVAR through those first 3 years, and that this association was strongest for the larger aneurysms, and we hypothesized that the biology of the sac can play a role. So we wanted to look at causes of mortality, so we brought in the patients from the LEOPARD study, and for those who don't know, this is a randomized trial comparing the Endologix AFX devices to other commercially available devices, which included the Endurant Excluder and Zenith grafts. And we combined them all together in the LEOPARD cohort and compared them to our NELIX group. And there's more women in the leopard cohort. There was a slightly higher rate of advanced kidney disease in the leopard cohort. They were more likely to have small aneurysms, less than 5 centimeters in the leopard cohort, and then they had wider necks based on the IFU. But after adjusting for all of that and then all of the demographic and comorbid conditions, again, we saw a difference in survival that becomes statistically significant at 2 years and remains so at 3 years, with higher survival in the EVAS cohort. Again, when we broke it down, looking at the smaller diameters, there was no difference. And in the larger diameters, there did seem to be a difference. It wasn't quite statistically significant, but then again, we have smaller numbers here now, very small numbers at 3 years in the leopard cohort. But certainly the suggestion is there, and it seems to fit the same pattern. But one thing we have in this cohort is cause of death. And while nothing is statistically significant, we see a couple things. Number one, cancer is the leading cause of death in both cohorts, but it made up 34% of the deaths with leopard and 26% of the deaths with EVAS. Cardiovascular mortality was similar in the two. Aneurysm-related mortality was uncommon in both groups, but less common in the Endologix group. Again, through the first 3 years. Renal disease was similar, pulmonary was similar, and all of the others were similar. So to summarize, EVAS in both of these analyses is associated with higher early survival compared to EVAR. And cancer is, interestingly, the leading cause of death for both cohorts, with a suggestion that maybe with higher numbers there might be a difference there, but obviously we need more numbers and more long-term follow-up. And eventually we'll probably see the impact of some of the migrations and reinterventions. We need to really tease out what's the impact of the SAC obliteration on overall survival. And our future work will be to take that VQI cohort, once we have them linked to Medicare data, and we can look at readmissions for cancer-related or cardiovascular and other inflammatory-related conditions to try to figure out why we're seeing this difference in mortality. Thank you very much.
Thank you very much for joining us on the panel.